Welcome. This presentation is a detailed overview of menopause, tailored for primary care physicians. We will cover everything from definitions and diagnosis to management strategies, ensuring you have a thorough understanding for practical clinical practice. Let's begin with definitions. Menopause is officially recognized after 12 consecutive months of amenorrhea in the typical clinical context, usually between the ages of 45 and 55. The transition phase leading up to menopause is called perimenopause, where hormonal fluctuations cause irregular cycles and vasomotor symptoms. From an epidemiological viewpoint, the median age in the United States is 51. However, this can vary based on factors such as smoking or surgical interventions. Menopause occurs as ovarian follicles decrease in number, leading to lower estrogen and inhibin levels. This drop prompts elevated follicle-stimulating hormone, or FSH. During perimenopause, FSH can fluctuate significantly, contributing to irregular bleeding patterns. Clinically, menopause presents with a broad range of symptoms. Commonly, patients experience vasomotor symptoms like hot flashes and night sweats. Changes in the genitourinary system, referred to as the genitourinary syndrome of menopause, include vaginal dryness, urinary changes, and sexual dysfunction. Perimenopausal menstrual irregularities often manifest as changes in cycle length, missed cycles, or unpredictable bleeding. Additional concerns can include mood swings, difficulty sleeping, joint aches, and an increased risk of osteoporosis over time. Menopause is generally a clinical diagnosis, especially in individuals over 45 with classic symptoms such as hot flashes and amenorrhea. We pay close attention to menstrual history, documenting the duration of amenorrhea, and evaluate symptom patterns, particularly vasomotor complaints. While often unnecessary in straightforward cases, laboratory tests can help in ambiguous situations. FSH levels above 40 IU gel and low estradiol levels support the diagnosis. Anti-Müllerian hormone, or AMH, reflects ovarian reserve but is less commonly used in standard clinical practice. A TSH test is also advised to exclude thyroid dysfunction. Pelvic ultrasound may be performed when evaluating unexplained or abnormal uterine bleeding. Differential diagnoses include thyroid disorders, hyperprolactinemia, pregnancy, and primary ovarian insufficiency if symptoms emerge before age 40. The primary aims of menopause management are to alleviate vasomotor and genitourinary symptoms, protect bone health, and maintain overall quality of life. Management can be divided into non-pharmacological and pharmacological options. Lifestyle modifications are foundational. These include a balanced diet with sufficient calcium, approximately 1,200 mg per day, and vitamin D, around 800 to 1,000 international units daily. Regular weight-bearing and resistance exercises support bone density, while smoking cessation helps reduce symptoms and improve overall cardiovascular health. Managing stress through methods such as yoga or meditation can also be beneficial. Hormone therapy remains the most effective treatment for vasomotor symptoms and genitourinary issues. It also helps maintain bone density. The decision to initiate hormone therapy must be balanced against potential risks, such as breast cancer and cardiovascular events. Key indications include moderate to severe vasomotor symptoms, genitourinary syndrome of menopause, and those with early menopause or high osteoporosis risk. Contraindications include known or suspected breast cancer, estrogen-dependent tumors, unexplained uterine bleeding, history of thromboembolic events, and significant liver disease. Estrogen therapy alone, prescribed for women without a uterus. Common forms include conjugated equine estrogens, oral 17-estradiol, transdermal patches, or topical gels. Typical doses vary. Conjugated equine estrogens, 0.3 to 0.625 mg daily, oral 17-estradiol, 0.5 to 2 mg daily, transdermal 17-estradiol patches, 0.025 to 0.05 mg per day, applied once or twice weekly, combined estrogen-progestogen therapy, needed for women with an intact uterus to prevent endometrial hyperplasia. This can be given sequentially, resulting in monthly withdrawal bleeding, or continuously, with daily estrogen and progestogen to minimize bleeding. Common progestogens include medroxyprogesterone acetate, 5 to 5 mg daily for continuous or 5 to 10 mg daily cyclic, or micronized progesterone, 100 mg daily continuous, 200 mg daily cyclic. Tibolone is a synthetic steroid with combined estrogenic, progestogenic, and weak androgenic properties, given at 2.5 mg daily, helpful for vasomotor symptoms and bone density maintenance. It's generally advised to start at the lowest effective dose and reassess periodically. There is no universally fixed duration, however, many guidelines suggest using hormone therapy for the shortest time that controls symptoms. Follow-up involves annual evaluations, including breast exams, mammograms, and risk assessments, cases where hormone therapy is contraindicated or declined. Non-hormonal treatments can effectively address vasomotor symptoms, SSRIs, and SNRIs. Examples include paroxetine, 7.5 to 12.5 mg daily, venlafaxine, 37.5 to 75 mg daily, and escitalopram, 10 to 20 mg daily. Gabapentin, often used for nocturnal hot flashes at doses of 300 to 900 mg daily. Clonidine may be useful for hot flashes at 0.05 to 0.1 mg per day, though side effects and efficacy vary. For genitourinary issues, non-hormonal moisturizers and lubricants can bring relief. Local low-dose vaginal estrogen is an option if symptoms are more pronounced, even in certain individuals who otherwise avoid systemic estrogen. Alternative therapies, including phytoestrogens found in soy, black cohosh, and lifestyle interventions like acupuncture or yoga, show varied efficacy. While some patients find these helpful, evidence is mixed, so it's important to guide patients accordingly. Certain populations warrant extra caution. Individuals with a history of breast cancer typically avoid systemic estrogen therapy, but may benefit from low-dose vaginal estrogen if genitourinary symptoms are severe. For those with increased cardiovascular risk, the transdermal route of estrogen may lower the risk of thromboembolic complications compared to oral routes. Women with osteopenia or osteoporosis should be counseled on treatments like bisphosphonates or SERMs if hormone therapy is unsuitable. Lastly, those with premature ovarian insufficiency commonly need hormone replacement until the average age of menopause to decrease cardiovascular and bone health risks. As primary care physicians, it's crucial to take a thorough history and risk assessment, evaluating family and personal medical history. Screening for breast cancer, monitoring bone density, and regularly checking blood pressure and metabolic parameters are part of comprehensive care. Therapy must be individualized, and annual re-evaluation is important to confirm ongoing necessity. Whenever discussing hormone therapy, it's essential to explain potential side effects and benefits, involving the patient in decision-making to achieve the best clinical outcome. In summary, menopause is a natural transition that involves far more than the cessation of menses. It includes a variety of symptoms, all of which can significantly impact daily life. Hormone therapy is the most effective treatment for relief of vasomotor and genitourinary symptoms, with careful consideration of each patient's risk profile. Non-hormonal approaches are also available and can be tailored to individual patient preferences or contraindications. Collaborative decision-making and periodic reassessment are pivotal to ensuring safe and effective management of menopausal symptoms. Thank you for joining this comprehensive look at menopause. For more detailed information, consider reviewing guidelines from the American College of Obstetricians and Gynecologists, the North American Menopause Society, and the Endocrine Society. If you found this lecture helpful, please like this video, subscribe for more in-depth clinical discussions, and share it with colleagues or anyone who might benefit. Together, we can advance the quality of care for women navigating menopause. Stay informed, stay compassionate, and keep learning.